Okay. Right, dear ladies and gentlemen, it's my pleasure to welcome you here. First of all, I want to thank our organizers of this Congress for their very important and successful job bringing all of us here. And it's very nice that not only this can be done over internet and in the very used to us mode, but also face-to-face. So my name is Professor Rudenko. I'm Allergy Immunology consultant from London, and I will be talking through allergy, diagnostic tools, and management for allergic rhinitis. First of all, I want to mention that I don't have anything to disclose with regards to this presentation, no conflicts of interest. First slides were kindly given to me by Professor Pat Smith from Australia. And indeed, we know that allergy is sensory. So it involves both neurological system together with all the immunological mechanisms of allergy. And in the center of this slide, you can see the central nervous system is playing a major role in it. And indeed, you can see that it's not only the allergy, and it's not that straightforward. So apart from the allergic sensitization and allergic mechanism, we have influence from lots of factors of the environment in day-to-day exposure. We can see tobacco smoke, fragrances, then lots of particles that modify the pollen, and as well as the allergens. Then we can see receptors, and through these receptors we can, that's the effect of amplification that is happening, and in the end that all results in symptoms that our patients experience. Let's talk about the mechanism of allergies, something that is pretty simple, but something that we need to know and manage to explain to our patients. So in the middle of this picture, we can see mast cell, and that's the main cell in the allergic inflammation. In order for the allergic reaction to happen, there should be an allergen sensitization through these IgE molecules, and these IgE molecules, they need to be sitting on the Fc epsilon R receptor, and there should be two of them specific to the same allergen in order to trigger the allergic reaction. So if these specific IgEs will be specific to different allergens, there will be no reaction. And that's something that we see in people with polysensitization, when there are plenty of things they're allergic to, and sometimes they say that they don't react to a particular allergen, and this is one of possible explanation to this phenomenon. So after that, after there is this happen, so when there is a cross-linking of these two IgE molecules, there will be a signal going, and there will be degranulation of mast cells. So we all know that there is histamine as a main chemical, but apart from histamine, you can see that there are plenty of other biological mediators that will be released. Many of them have significance and importance. For instance, we can see here platelet activating factor that can be also addressed by one of our treatment plans. So let's see what's actually happening in the tissue, in the mucosal surface of the nose. Alongside of blood vessels and alongside nerves, these are the mast cells. They're sitting, you can see the blood vessel, and then what on the blood vessels, we can see receptors to histamine. When these receptors of histamine are taken by the histamine that's released from the granules in mast cells, there will be a signal going to the nerves and the Also, there will be relaxation of blood vessel, and this blood vessel will open up, and there will be the water will start leaking out of the blood vessels, and there will be swelling. That will also affect the nerve endings, and also people will experience itchiness as two main problems. We will touch upon this in the treatment part, but you can see this can be all efficiently treated by blocking these receptors. It's not happening like that as it's sort of shown on this slide. It's more complex mechanism of switching off the receptors, but for simplicity, the antihistamines can block these receptors instead of histamine, and then these symptoms will be less prevalent for these patients. So how do we diagnose allergies? So when we do tests with the patient, we are going to use the same mechanism in order to elicit an allergic reaction on the skin and detect this and measure it. So I'll just go with a step-by-step process how to do skin prick testing. So first of all, what we will need a patient, and we will need our skin prick test kit. Firstly, we mark the skin with the numbers of the number of allergens we're going to use. This is all controlled with positive and negative control that we usually have it in the beginning of our box. And we put the positive and negative control on the skin, followed by the panel that we want to test. After that, we will use the sort of single-use prickers, and one pricker is pricking one drop in order to avoid all cross-contamination. And that's how it will be done. So we will prick through the drop into the skin. It does not need to come through the skin. It's just a tiny little touch. We usually depress the skin a little bit to obviously avoid getting through the skin. And what also we do, you don't see a lot of veins on this particular patient, but if there are many veins, you don't put on top of the vein, you just avoid the veins just not to give the allergen intravenously. Then it's all pricked, and then we need to wipe out the excess of the fluid and wait for 15 minutes, and then we will start measuring the results. When the results are shown, we are measuring them using the ruler. It can be done using this scale, or you can measure actually by the standard usual way. So we usually measure 2 maximum diameters. So that, and we'll turn the ruler and we'll measure it the other way. And we'll write this down in our records of what actually the patient is allergic to. And that can be given to the patient and used for further judgment. Then we will use some sort of makeup remover to remove the numbers, and if needed, we can put a bit of antihistamine cream on the arm so there is no, the irritation is less. Now let's talk about the tests that you can do in the laboratory. So you can see the Fandia machine with Immunocap. So each and every pen that you can see here presents a different allergen, and when it is analyzed, we can measure them one by one. So this is pretty much the same method, but using the components, and this is the microchip that has on each and every of these slides 112 different allergens done in triplicates. So it's triple checked, and you can see that that's what the reading looks like. So there is obviously change in color, and the mechanism of this test is that they're pretty much the same what you have in cup or in this ISIAN, that's the ELISA method. So you have the allergen absorbed either to the glass or to the well. Then the allergen is sort of present here. Then you add the patient's serum. the specific IgE that is in the serum will attach to this allergen, then everything is washed, and then you add fluorescence anti-IgE, and that will actually change the color, and then you can measure it and give the results to the patient. The only thing that we need to be aware of when we're using this test is something that is called hyper-IgE syndrome, or very high total IgE. The ISIAN test is less affected by it because you can see that the glass is flat. When you do the same thing in the well, that can result in the residual IgE antibodies staying there after it's being washed at one of the stages of the process. And as a result of that, this can lead to false positive results. And this is something that we need to be aware of. The measuring total IgE in day-to-day practice is not that informative for us. It's used mainly in the situation when everything is positive on your test and you need to explain why. So here we can see the results of component test ISIAN. It not just gives us positive and negative for, or the grade for the whole allergen, but it breaks it down to different components. So you can see for the grass pollen in here, you have from FLIPI1 to FLIPI5, and you can see degree of sensitization. That is quite useful for some allergen in terms of we can see what is the main allergen that the person is allergic to when we select them for treatment for immunotherapy. It also helps to determine if the patient in front of us has oral allergy syndrome, if there is sensitization to BATV1 in the Northern Hemisphere. That's mainly stands for sensitization to birch pollen and cross-reaction with all different allergens that are looking same to the immune system. And these cross-reactions can be slightly different. So you can see the cross-reactions between grass and birch, cross-reactions to food, cross-reactions between the animals and milk. So that can be seen, and also mites and shellfish. How to manage the patient with what are the steps? So you can see that there is a treatment algorithm, and it starts with evaluation, clinical evaluation, how bad the symptoms are. So if there is mild symptoms, we try treatment with antihistamines. We can use the intranasal steroids, and then we can assess after time period what have we achieved. So if there is control achieved, we obviously see what's the long-term plan and then manage the patient accordingly. If there is not complete sort of effect of our treatment, we can use the combination of the intranasal corticosteroids and antihistamines local. And further, we can see whether there is improvement in there, then assess what can be added onto it. So if there is a water run area, the ipratropium can be added. Then we can add oral antihistamines, leukotriene receptor antagonist when there is catarrh or if the patient is asthmatic. Sometimes this is not something that we advocating in the clinic, the sort of short courses of decongestants. We don't use that. But again, if that is not helping, then we need to reassess what is the underlying cause, if there is any surgical problem, if there is anything that will lead us to the diagnosis of non-allergic rhinitis, where this is confirmed allergic rhinitis and we can proceed to immunotherapy, or looking for other diagnoses and other sort of recreational things that sometimes also happen. So the usual treatment plans, this is the new second-generation antihistamines. We obviously not recommend use of the first generation due to its drowsiness, and the second-generation antihistamines available everywhere. this is why it's a pretty sort of easy choice. It's more than sort of on the education platform that you need to advise your patients that the first generation antihistamines are not there. Unfortunately, we see lots of advertisements on the radio, television, and so on for the old antihistamines, and that's obviously done on purpose. And yeah, people tend to know them and choose them because there is the sort of quite long history of them being present on the market. So what's available? I'm just talking about the UK. We have over-the-counter medication that is in there. So levocetirizine and cetirizine. Then we have loratadine. So cetirizine and loratadine is available over the counter. Levocetirizine on prescription. Fexofenadine on prescription, and desloratadine is also on prescription. Rupatadine as well. That's intranasal preparation. In comparison, there can be mild sedation with the cetirizine and levocetirizine, less of that with loratadine. And this is for some patients, it's not for everyone. Some patients are taking cetirizine without any problems. We need to know about the metabolic interaction with the fexofenadine, so it does not agree very good with grapefruit juice. Then talking about first generation of antihistamines, why it's not a good idea. So that's the study from Germany done, the study from UK done by Martin Church, when they did encephalogram, and before giving first generation antihistamine, measured the sleep pattern with the active sleep, REM sleep, and then person being awake, and showing that everything is pretty good and normal. And then they gave them first generation antihistamines and continued monitoring. So the REM sleep was delayed and was reduced. So that led to the person not being able to relax properly during the night and rest properly. So the next day they were drowsy and tired. And this is very important to emphasize to your patients, that drowsy antihistamines, they do not make you sleep better. And there is no point giving them as a sleeping remedy. But in fact, they will reduce the ability to sort of recap or relax during the night and have a proper sleep. So this is why they should not be used. So this slide demonstrates the different steroid preparations that can be administered, and they're by availability in the bloodstream. So some of them are quite sort of significant. For most that are used nowadays, they're pretty little. Again, this all needs to be judged with the patient and the function of the immune system, and it also because it needs to be assessed while you're taking the history. If someone will tell that they have lots of infectious illnesses during the year, if they have several cases of chest infections or urinary tract infection or sinus disease, so that's something that we need to be asking, because if a patient has immune deficiency, that can be exacerbated by using even the sort of types of the intranasal corticosteroids that have lower bioavailability. But the next point will be talking about antihistamines, just to remind you about this effect that we were talking before. So first line choice falls to azelastine. So azelastine, it's a very good antihistamine that has triple effect. So it affects, so obviously it gets in the nose, and it has properties of antihistamine, properties of mast cell stabilizer, and anti-inflammatory properties. And this is why, if it's used correctly, it gives quite significant improvement in symptoms. So I'll show you how to use nasal spray and the eye drops on one of our slides in here. So firstly, it's pretty much the same for intranasal corticosteroids and for antihistamine. The position of chin to the chest, alternated hands, so right hand to left nostril, left hand to right nostril, and nose sniffing in. So holding breath, doing sprays into both sides, and then there can be following maneuvers done. In the position head down, that will administer or distribute this product into the right place. This is for using drops in the nose. The next question is also very important. It's regarding the use of combination of different antihistamines. This is what we very often hear in practice when the patients are taking several antihistamines at the same time, hoping that they will achieve better effect. So this trial showed that combination of two or three antihistamines given during the day has lesser effect than the high dose of the same antihistamines. So if the patient will choose to, if one is not working and they choose to increase the dose, doing it by mixing different antihistamines is not a good idea, just because of that. So the next point is just to show what antihistamines are doing. So obviously, as we discussed, they're blocking receptors on blood vessels and nerves, and there is a role of H1 and H2. We don't necessarily need H2 antihistamines for allergic rhinitis. They're mainly used in other conditions, but theoretically, they can be used as well as an add-on if needed. What about the anti-IgE treatment? Because of the costs, it's not something that you would use in ordinary allergic rhinitis, but if it is combined with asthma, or if we use it, for example, for urticaria, the patients usually forget about their allergic rhinitis at the same time. Obviously, it's financially not a viable solution for allergic rhinitis, but that's something that was researched in various trials. So we can see that the evidence of the allergic rhinitis working in chronic rhinosinusitis with asthma, and as well as allergic rhinitis and asthma, and they block free circulating specific IgE, and eventually we can see that there is effect on the degranulation of the mast cells and improvement in the condition. So let's talk about specific immunotherapy. So that's a big topic that we will address, and you for sure will ask lots of questions in the end, but we have two modalities of that, doing subcutaneous immunotherapy and sublingual. The choice of the treatment is mainly now is going towards the sublingual because of the current pandemic, and making it very difficult for people to have the injection treatment. For some, if we sort of step aside and talk about venom immunotherapy, we don't have any other option rather than doing the injections. For the allergic rhinitis, the immunotherapy is working very well. It's working better if there is sensitization only to one allergen rather than a mixture, or if you manage to find out the main allergen that's causing problem. So if there is a big range of things, it's usually more difficult to manage. Possible, but more difficult. So that's the letter that we got from one of our patients who had her son treated, and she asked to the treatment for her as well for the next season. So we can see that from the Cochrane review that the treatment is improving the symptom score and medication score, and also the mechanism is increase in blocking antibodies of immunoglobulin 4. It was shown effective in the pretty old clinical trials, and also from what is needed for this treatment, it's pretty long-lasting treatment. So if we talk about sublingual tablets or sublingual sprays, it sort of takes quite a lot of medication that the patient will need to take. It's 3 years minimum. There is very little risk of any sort of reactions when it's done as in sublingual nature. There is a possibility of systemic reactions in people who have subcutaneous immunotherapy. It's a pretty expensive thing to do, but we need to know that this is the only treatment that will turn the allergic inflammation upside down and has a potential to make these people not allergic. So why and when it's used? It's for treatment of allergic rhinitis plus minus conjunctivitis, plus minus allergic asthma. It's also used in, and mainly used in venom reactions, systemic reactions to wasps and bee stings. So we need confirmation that this is an IgE-mediated problem with skin prick test or with specific IgE test. And obviously the avoidance is a very important advice that we can give to the patients if this is something that is possible. So when not to do it? So it's not done when it is uncontrolled asthma, when people are on beta blockers. In case of venom immunotherapy, obviously there is a discussion how to get around this in case when you have to do it. That's malignancy, that's autoimmune inflammatory condition, especially when they're active. It's pregnancy. We do not start any form of immunotherapy when the patient is actually pregnant, but we obviously continue it without any problems if they get pregnant during the course of the treatment. And you do not do it in case of do not start in case of the acute illness. And the same is valid when you're giving it as an injections. You obviously need to make sure that they don't have an active infection when they come for their next injection. So it requires good staff, good protocols, presence of emergency medication and documentation. So this is relevant for subcutaneous immunotherapy. It has to be done if we're talking about, again, subcutaneous treatment only in the hospital settings with the access to resuscitation. According to UK guidelines, the patients have to stay 1 hour after the injection. If this is done in the setting where you have several patients at the same time, it's obviously you need to be able to observe all of them, so it's not a good plan for them to come and sit in the corridor and wait while you're dealing with other patients. So they need to be in the same big room where you can have a good view on all of them. And it needs to be close to other people who can help in case of you experiencing problem. So it has to be done by 2 people, so you need to have 2 pairs of eyes to check the doses, to check that you have the right patient, and obviously if there is a need to help in case of severe systemic reactions. You need to be capable of recognizing severe allergic reaction anaphylaxis, and obviously be experienced in doing what you're doing. The main, both you and the nurse, if it's done, or if it's done by nursing team only, both nurses, they need to be have attention to details, because it's very, very important that everything is done according to the protocol, that even as slightest details that not look right, they need to be picked on and discussed. That might, in many cases, avoid severe problem and reaction. So what is done to treat anaphylaxis if anaphylaxis can occur? So it's treated with intramuscular adrenaline, 1 in 1,000. Then you have all generation antihistamine. Unfortunately, we don't have any injectable antihistamines of new generation, so there's a clofenamin that is available in injections. Hydrocortisone is used to prevent biphasic reaction, so it has very limited use or very limited effect for the management of the current episode right now, but it can prevent the biphasic reaction, and obviously you need fluids. So this is the spectrum of things that you would do. When you select people for immunotherapy, you obviously select them. They need to be an active participant with this discussion. They need to understand what they're signing for and what is going to happen over the course of the treatment. If we are talking about the sublingual route, it's easier to do from the point that the patients do not need to come to the clinic that often, but all the responsibility for treatment is transferred to the patient. So they need to clearly understand what they need to do and how they need to do it. And the first dose of the sublingual immunotherapy should either be taken in the hospital or under close supervision. So it's not, they usually do not experience any side effects or reactions. So apart from slight swelling or a little tingling, nothing is going to happen. But they need to know how to use it correctly. It's quite expensive treatment, and there will be lots of waste and lots of disappointment if that will be all wasted. The retention of the immunotherapy, unfortunately, is not great. Although it's the best treatment that you can give to your patient, it's very long in duration. And unless the patient is very motivated and is willing to do the whole thing from start to finish, it will obviously will not give the benefit you expect and they expect if they will not be taking it every day and will keep it under the tongue for 2 minutes. So that's very important that it is done the right way. And also the treatment, it needs to be without interruptions. It has to be in the fridge, and it's the fridge item, so they keep it in the fridge at home. When they travel, it's obviously something that makes it slightly different, although it's usually there is enough time for it to be transported and the stability is quite good, but still it's something that makes it difficult because sometimes people forget it, sometimes people lose it, sometimes the luggage is lost, sometimes there are lots of scenarios that we've been through with our patients with regards to this treatment. And obviously, if you discuss this all with them up front and they understand what to do and they know and they are actively participating and they know that if they will do it the right way, the chances are that they will be pretty much symptom-free, and that can last for a long period of time, and they might not need all the medications that they were taking beforehand, then obviously that will make them feeling much better. So with this, I want to basically conclude this presentation, and if you need contact details, here they are on the screen. And what I will want to ask you is to reflect on what you've just heard and what sort of difference it might make for your practice, and sort of happy to take your questions and discuss this interactively. If you have anything you want to discuss and address, I'm really happy to take your questions. So anyone, anything, maybe cases from your practice, maybe something that you have. Yeah, please.
Hi, my name is Patrick. I'm from Denmark, and in Denmark, it's very usual that we refer these patients to the respiratory medicine or respiratory doctors for intralymphatic injections. Mm-hmm. Do you have any experience with that?
To be honest, it's something that might be happening in the future. In the UK, we don't have it, and it's been researched. It was sort of shown in several papers, mainly in Switzerland. Which country are you from? So it's something that is practiced in some countries in Europe. We don't have this approach, but obviously when you inject it into lymph nodes and it gets sort of straight to the sort of system, the effect was shown to be better. But obviously you need to know where you're injecting, and you need to have the skills, and sometimes you need to have the ultrasound sort of to inject into the right place. So that's all slightly more complicated, but possible and doable. But from the routine practice, we don't use it. Right. Any more questions? Anyone? Okay, perfect. Right. So if we don't have any further questions, so we can finish with this. And yeah, I wish you further and very fruitful Congress.